We are live.
Okay. So, welcome everybody after a long break. So, we are again in the classroom, and today's student discussant is basically Dr. Anwitha from Nizam Institute. She is a third-year senior resident in nephrology. Welcome, Anwitha. And we are delighted. I am delighted basically to introduce Professor Kumar, and he is presently a professor in nephrology and is the head of the department in the Indira Gandhi Institute of Medical Sciences, Patna. He has a vast experience in nephrology for last 25 years, and he had been the examiners in the DM and the DNB courses in more than 10 universities. Also, he is a medical council or NMC assessor of the nephrology courses. He has lots of publications in the national and international journal. He was the past president of ISN East Zone, past vice president of ISN.
Good morning. Sorry, my internet connection.
Okay, welcome.
Good morning.
So today your examiner will be Professor Kumar. I was just introducing him. And yes, he is a past vice president of the Indian Society of Nephrology and is presently a member of the scientific committee of the same. He is holding lots of positions, including the expert board of studies in SGPGI Lucknow, and he is a number of heading the number of committees in the in Patna medical colleges, different medical colleges, and but in one line, he is a very knowledgeable person and he is very close to my heart. So we are not wasting much time. So initially you will be, Anwitha, you will be presenting your case, and it is kind of a examination come discussion come learning, everything will be there. At the end of this, there will be a OSCE session and Dr. Rabiranjan is there. And he will give you the OSCE questions. You have to read the questions and give the answers. And after that, the other people are there, they'll discuss. Okay.
Yes. Yes.
So, we are starting our presentation today. You start your case.
Yes. Good morning, everyone. So here I am presenting the case of Mrs. V. Dharmava, 60-year-old female farmer hailing from Nizamabad district, Telangana, who presented to us with the following complaints: history of generalized weakness since 15 days, history of anorexia since 15 days, history of fever since 7 days, history of breathlessness since 5 days, history of multiple episodes of vomiting since 5 days, history of progressive fall in urine output since 3 days, history of cough associated with pink frothy sputum since 1 day. She has no previous known comorbidities and was apparently all right till 15 days back, when she developed the symptoms of generalized weakness and anorexia. She developed low-grade fever not associated with chills 7 days ago, which was present on and off since then, reduced temporarily on taking tablet paracetamol with no diurnal variation. She gives history of breathlessness since 7 days, which was initially present on exertion during day-to-day activities, which progressed such that she is bedbound due to breathlessness since 1 day prior to presentation. It is associated with orthopnea. There is no history of chest pain, palpitations, or syncope. She gives history of multiple episodes of vomiting, bilious, not blood stain, not related to food intake, not associated with abdominal pain, abdominal distension, feculent spell, constipation, obstipation. There's no history of bloody in stools or melena. She gives history of reduced urine output since past 3 days. And she has noticed that there is progressive fall in urine output such that since 1 day prior to presentation, she is passing urine only once a day, approximately around 100 to 150 ml. She gives history of cough associated with pink frothy sputum, which worsens on lying down since 1 day. There's no history of noticing blood in urine, no history of noticing cola colored urine. There's no history of burning micturition. On inquiry, she gives history of noticing swelling, mild swelling in feet up to ankle. There's no history of facial puffiness or generalized swelling. On inquiry, there's no history of skin rash or joint pain, no history of oral ulcer, epistaxis, nasal ulcers, No history of no history of noticing tingling or numbness of limbs. There's no history of limb weakness. There's no history of seizures. No history of altered consciousness. There's no history of redness of eyes. No history of noticing floaters in vision, or no history of noticing bulging of eyes. There's no history of intake of any tablets prior to the onset of her symptoms. No history of noticing weight loss, and she doesn't give history of noticing mass anywhere in the body. On past history, there's no history of, she's not a known case of hypertension, diabetes, coronary disease, stroke, no history of tuberculosis in the past, not a known case of bronchial asthma or COPD. There's no history of epilepsy. She has not undergone any surgeries in the past. There's no history of drug allergy, no history of previous hospitalizations or blood transfusions. Personal history, her sleep is disturbed due to breathlessness. Her bowel habits are normal. Bladder, she has reduced urine output since past 5 days. She consumes mixed diet. Her appetite is reduced. She chews tobacco since the past 15 to 20 years. There's no history of other addictions. Family history, there's no significant family history. Menstrual history, she's postmenopausal since the past 15 years. Obstetric history, she is a mother of 5 children. All deliveries were normal vaginal deliveries at term with no complications. Once she presented with these symptoms, at presentation, she was told to have a serum creatinine of 12 milligrams, and she was started on hemodialysis via catheter inserted on her neck vein. She was told that she will be planned for renal biopsy after her creatinine comes down. But after 3 days of admission, she developed sudden worsening of breathlessness, for which she was put on ventilator support. She was her relatives were told that she'll need blood transfusion as her hemoglobin has suddenly fallen from 9, which was present at admission, to 5. She was told to have blood leakage into the lungs and was started on steroid injection after steroid injection. She was also told that she will need special type of dialysis, and she was started on this special dialysis daily. After 3 days of this special dialysis was given along with followed by the regular hemodialysis. After the first 3 sessions of the special dialysis, she developed new onset worsening of fever and was told to have infection in her lungs and was hence started on IV antibiotics. Her relative also gives history that she was also given IVIG injection. And along with antibiotics, she was continued on this special dialysis. 4 more sessions were given on alternate days along with the hemodialysis. And during the course of this special dialysis, along with hemodialysis, she has received 5 packets of red blood transfusion. She was removed from ventilatory support after 10 days. And she was planned for further treatment. She was told that she'll need an injection once in 15 days, but was told that at present it can't be given because she has persistent infection in her lungs. She subsequently underwent renal biopsy. So on examination, at admission on examination, she was conscious cooperative. Her pulse was 130. Her blood pressure was 154/102. Her saturation was 80% on room air, and on oxygen it was by face mask it was 85%. Her JBP was normal. Her respiratory system had on exam she had pallor. There was no icterus, cyanosis, clubbing, lymphadenopathy or edema, and her breast, spine, oral cavity, nasal cavity, conjunctiva and skin examination was normal. On systemic examination, respiratory system exam, there was bilateral crepitations and occasional rhonchi, which was diffuse. Cardiac examination, S1, S2 was normal. There was no pericardial rub or murmur. Per abdomen, it was soft. There was no palpable organomegaly. CNS examination, there was no obvious focal neurodeficit. This was on admission. At the time of examination, when taking history, on examination, her pulse was 92 per minute. Blood pressure was 124/92. Respiratory rate was 16. Saturation was 100% on room air. She had mild pallor. Respiratory system, there was left-sided occasional creps with bronchial breath sounds. So, shall I summarize my case?
I think based on your history examination and a short hospital course. So till history and examination, what is your summary and provisional diagnosis?
So here,
Hospital course.
excluding the hospital course.
Yeah.
Yes. So here I have a 60-year-old female who is a farmer with no previous comorbidities, who has presented with rapid onset generalized weakness, anorexia, fever, breathlessness associated with orthopnea, cough with pink frothy sputum, multiple episodes of vomiting, and reduced urine output. Her syndromic diagnosis would be rapidly progressive renal failure, with the probable etiology of rapidly progressive glomerulonephritis presenting as pulmonary renal syndrome. And my differential diagnosis for this would be systemic small vessel vasculitis presenting with the rapidly progressive glomerulonephritis.
Your syndromic diagnosis is rapidly progressive glomerulonephritis.
Yes.
Apart from RPGM, what else? You have told pulmonary renal syndrome.
Yes, sir.
So with this history and this provisional diagnosis, what are the other differential diagnoses in this patient?
So patients who come with this presentation, this pulmonary renal syndrome can occur due to non-renal causes also. So a patient who has underlying cardiac failure.
Stick to the differential diagnosis of RPGN first.
Okay, sir.
The commonest cause of RPGN.
Okay. So it can be immune complex associated glomerulonephritis with the crescentic transformation. It can be this thing, small vessel vasculitis, that is ANCA vasculitis causing immune glomerulonephritis. It can be anti-GBM disease presenting as RPGN. Then other causes can be patient with the autoimmune disorders such as SLE with lupus nephritis. It can be if there is an underlying associated arthritis symptoms. It can be rheumatoid arthritis with crescentic GN. Patient can have IgA nephropathy presenting with.
So your diagnosis, first diagnosis is small vessel vasculitis.
Yes.
Whether it is ANCA associated or immune complex associated. So how you will confirm the diagnosis?
History-wise, sir.
History-wise.
So if first thing is the age, in terms of age, considering that this patient is 60 years old, the differential diagnosis of ANCA vasculitis or immune complex or anti-GBM disease becomes more likely rather than IgA nephropathy, lupus nephritis, and other causes. And rheumatoid arthritis, there's no history of arthritis of symmetric polyarthritis. So rheumatoid arthritis associated vasculitis is also ruled out. So now differentiating between, yes.
Your first diagnosis is ANCA associated vasculitis or immune complex mediated vasculitis?
Sir, she has a history of fever also. So considering that there was history of fever and all these findings with acute onset oliguria and breathlessness, immune complex glomerulonephritis becomes my first differential diagnosis just from the presenting history.
What is the classical presentation of small vessel ANCA associated vasculitis?
So ANCA associated vasculitis, they can present with RPGN, and they may have cutaneous manifestations. Cutaneous manifestations such as palpable non-pruritic purpura, which are non-blanching, and they can have polyarthralgia. They can have involvement of other systems, that is involvement of along with musculoskeletal system. There can be nervous system involvement, mononeuritis multiplex, which is less common. Then ocular involvement can present with uveitis, which presents as floaters in vision. And if the patient if the patient has PR3 ANCA vasculitis, they can have upper respiratory tract involvement. So upper respiratory tract involvement can present in the form of epistaxis. They can have reduced hearing because of otitis. They can have sinusitis. And lower respiratory tract involvement, they can have subglottic stenosis. Then that can present as.
So your first provisional diagnosis is immune complex mediated.
Yes.
RPGN.
Yes.
So among immune complex, what is your diagnosis?
I didn't get you, sir. Sorry.
Among immune complex
Yes.
mediated small vessel vasculitis, what is your first diagnosis?
So, IRG, infection-related glomerulonephritis, is the first differential diagnosis among the immune complex glomerulonephritis, because there is history of fever prior to for 1 week, which was present along with malaise and generalized weakness. So that fever for 1 week was followed by onset of her other symptoms. However, the thing that goes slightly against is that it is a very short history. For immune complex formation and glomerulonephritis development, at least 2 to 3 weeks is required.
So in IRGN, you get the RPGN plus alveolar hemorrhage so commonly?
Alveolar hemorrhage is not common, sir. This pink frothy sputum at presentation could have been because of her pulmonary edema, which was present because she was in acute volume overload because of oliguria. So that is why we can't still differentiate whether it is pulmonary hemorrhage or pulmonary edema.
Now you give the clinical summary of your patient. Your patient presented with RPGN sort of presentation with advanced renal failure. She required dialysis immediately after dialysis with pulmonary edema. So what is your complete diagnosis?
She is RPGN with the pulmonary renal syndrome, sir.
Pulmonary renal syndrome.
Probably
so,
due to
confirm this your diagnosis.
so
or
probably
other possibility of differential diagnosis.
So other than small vessel vasculitis. Yeah. So other than immune complex glomerulonephritis and small vessel vasculitis, considering her age, we also have to consider anti-GBM disease presenting in this manner. Then other differentials would be cryoglobulinemia secondary to underlying hematologic malignancies such as multiple myeloma, again considering her age. Then other differential would be these are my.
They all come into the category of small vessel vasculitis.
Yes.
It is ANCA associated or immune. How you classify small vessel vasculitis?
So small vessel vasculitis is classified into pauciimmune and immune complex vasculitis. So okay. Pauciimmune is microscopic polyangiitis, granulomatosis with polyangiitis, eosinophilic granulomatosis with polyangiitis, and renal limited vasculitis. Immune complex vasculitis is classified into cryoglobulinic vasculitis, anti-GBM disease associated vasculitis, anti-C1q vasculitis, and IgA vasculitis.
What are the positive findings on examination in this patient?
On examination at presentation, she had hypertension, which she previously did not have. It was 156 by 104. However, it was not usually a patient who has IRGN who presents with presenting transformation. Usually it will be accelerated hypertension. So that accelerated hypertension was not present. So from taking just the BP into consideration, it was slightly against immune complex glomerulonephritis, sorry, IRGN. Then other findings was that she had hypoxia, so which was persistent even after giving dialysis. So if that hypoxia was just due to pulmonary edema, considering that she was given 3 dialysis back to back, that hypoxia should have settled, which was not settling. Then she had pallor, which worsened during the course of her ward stay. So that was the other significant finding, and respiratory finding of bilateral crepitations.
What is the importance of hypoxemia in presence of pulmonary syndromes?
So presence of hypoxemia points towards presence of possible presence of diffuse alveolar hemorrhage or extensive nodular cavitatory lesions with superimposed infection. So diffuse alveolar hemorrhage, for us to identify it, we either have to do HRCT test or diffusion capacity of lung for carbon monoxide, or BAL analysis to see for macrophages containing hemocytes.
Does it impact your decision of treatment also, whether to
yes.
go plasma exchange?
Yes. Yes. So patients who have diffuse alveolar hemorrhage with hypoxemia, there are KDIGO guidelines say that plasmapheresis has to be considered. Whereas if there is no hypoxemia, we can just give other treatment.
So now you enumerate how you will investigate this patient so that your diagnosis is confirmed and other diagnoses are ruled out.
Yes. So first I would like to start off with the complete hemogram of the patient, and I would want to monitor it through the course of ward stay. In that,
So
I would
your
like.
patient is having anemia. So what
Yes.
type of anemia are you expecting in this patient?
Here we would expect iron deficiency anemia if she has had recurrent episodes of bleeding that would cause iron deficiency, or if since it is
You
since
mean to say that microcytic hypochromic anemia, or you are
yes,
expecting?
yes.
What else
And,
you will get completely?
as a part of if there is an underlying autoimmune etiology, as a part of autoimmune etiology, she may have thrombocytopenia also. And since she gives history of fever, I also want to look for presence of leukocytosis, because if she has an underlying infection, that would change my treatment approach to the patient. So in terms of immunosuppression, so that is
at this point of time, it is very important to rule out presence of any infection, because
yes.
probably in this patient, you are going to plan aggressive immunosuppressive therapy.
Yes.
What else apart from CBC?
So other than CBC, I would like to look for renal function test, that is urea, creatinine, her electrolytes, sodium, potassium, chloride, calcium, phosphorus, uric
What is
acid.
the importance of KFT, level of serum creatinine?
Yes. So the level of serum creatinine again tells us regarding the severity of the disease. If the patient has creatinine of more than 5.7, it is considered as severe renal involvement. So our treatment has to be aggressive for that patient. Whereas if it is less severe, then we can consider less aggressive treatment course. And also, since we will have to plan biopsy for the patient as we are giving hemodialysis, we also want to monitor the creatinine, so that creatinine and urea, so that we can avoid bleeding complications secondary to uremia.
So level of creatinine at entry point is important both in small vessel vasculitis and anti-GBM. So what is the difference in treatment policy?
So if in small vessel vasculitis, if the patient has a organ threatening or life threatening disease, so in terms of kidney, the creatinine more than 5.7 is a organ threatening disease. So in such patients, we have to consider in induction along with IV methylprednisolone. We also have to consider cyclophosphamide and plasmapheresis.
Right. So you have to be aggressive in immunosuppression. While in anti-GBM disease?
In anti-GBM disease, severe disease that is serum creatinine more than 7 is considered to be advanced presentation. And in such patients, for prognostication, it helps, because in such patients, they are more likely to become dialysis dependent. So in such patients, it is said that we have to give aggressive immunosuppression if there is presence of crescents on renal biopsy for 4 weeks. So after 4 weeks, if the patient does not respond, we have to plan stopping immunosuppression. So creatinine more than 7 in anti-GBM is where.
What other investigations? KFT.
Other than RFT, I would also like to do liver function test, because she is complaining of abdominal pain and multiple episodes of vomiting. So given history of fever for other organ involvement, multi-organ involvement, I also want to do liver function test. Also serum albumin will also help me identify. Then urine analysis. Urine analysis, I would like to see for the protein and presence of hematuria with dysmorphic RBCs, and this will point towards a underlying glomerular etiology. So hematuria more than 3 RBCs per high power field, if it is
right.
present.
So by urinalysis, we will confirm the diagnosis that patient is having glomerulonephritis.
Yes.
What else?
Then other than that, I would, since she has oliguria spot, protein creatinine ratio will not be helpful, because it will not reflect the true this thing. Other than that, I would also like to do autoimmune workup, complement levels, because immune complex glomerulonephritis is my first differential. Then other than that, I would like to do ANA, then ANCA by immunofluorescence and ELISA.
What is the significance of measuring complement levels?
So if the C3 levels are low and C4 level is normal, that point towards a probable IRGN as the cause of
just give the basic knowledge.
Yes.
By measuring complements, if the complements are low, then what it signifies?
So if complements are low, it is either immune complex mediated or autoimmune lupus associated or probable underlying cryoglobulin.
It tells about the underlying immune complex disease.
Yes. Yes.
What are the conditions in which both C3 and C4 are low?
In SLE, both C3, C4 can be low if the patient
in other words, you can say whenever the classical pathway is involved, there will be both lowering of both C3 and C4. If only C3 is low, then
alternate pathway.
Tell me some conditions where both C3 and C4 are low.
So patient with the systemic lupus erythematosus, SLE, essential mixed cryoglobulinemia, they can develop along with C3, they may develop low C4 also. Then patient
what are the non-immunological condition where complements are low?
Patient with chronic liver cirrhosis, they can have deficiency of synthesis and they can develop malnutrition. They can develop.
No, any condition where complements are high?
Not sure.
So we will discuss it later on. So we have done complements. Then you have told about ANA and ANCA in this patient.
Yes.
What you will get in ANA?
The ANA can come false positive also if the patient has an underlying malignancy or infection. So it is not specific. So, however, if it is positive, I will have to work up further for underlying autoimmune disorder. And
ANC, you have told about ANCA.
ANCA. So ANCA initially I'll do it by immunofluorescence. So that will point us towards whether it is a perinuclear or cytoplasmic pattern. Then ANCA ELISA will further tell us if it is MPO ANCA or PR3 ANCA, and this will help us prognosticate.
You will send the sample for indirect immunofluorescent or ELISA, or both?
If I am given only one option, then I would prefer ELISA.
PR3 or MPO.
Yes.
So directly you can send this for ELISA testing.
Yes.
Okay. So immunofluorescence is done for screening of ANCA.
Yes. Yes.
And those two patterns you discussed, C ANCA and
P ANCA.
P ANCA. What is the importance of identifying these particular antigens?
So there's a clinical difference in terms of clinical manifestations and outcome also. So PR3 ANCA, it involves upper respiratory tract and lower respiratory tract more often. Whereas MPO ANCA, there is renal involvement more often. PR3 ANCA, it is a more aggressive disease and it is more prone to develop relapses. Whereas NPO ANCA, it is less prone to develop relapses. So other than that, in PR3 ANCA, the chance of them having pulmonary nodules and cavities is more. MPO ANCA, the chance are less.
So now coming back to this patient, what investigations have been done? You have asked for, and what are the?
Yes. So her complete blood count, initially it showed hemoglobin of around 9.1, sir, and total count her total count was 10,700, platelet was 3.08 lakhs. However, during the course of ward stay, when on the day she got intubated, her hemoglobin had fallen to 5.4. Total count and platelets were normal. Her C3, C4 was 91 and 22, which was normal. Her ANA was 3 plus speckled. ANCA, P ANCA was positive by immunofluorescence. Later, ELISA was sent. MPO ANCA had come positive. Her urine analysis showed albumin 3 plus, RBC is more than 50 and WBC is more than 50. And creatinine on admission was 12.6. And her HRCT chest on admission, it was done. There was just pulmonary edema. However, it was repeated on the day she got mechanically ventilated, and that CT chest showed diffuse alveolar hemorrhage.
Now, with all these investigations, please tell me the complete diagnosis of this patient.
So this is a patient with rapidly progressive glomerulonephritis, pulmonary renal syndrome, secondary to MPO and the small vessel vasculitis.
MPO, ANCA, associated vasculitis. Anything else?
With the diffuse alveolar hemorrhage causing type 2 respiratory failure.
Okay. So now we have to plan treatment in this patient.
Yes.
So please tell me how you will manage this patient in your emergency room.
So
hyperkalemia 6.4. Patient was 6.4, no?
yes, sir, on admissions.
Yeah.
So immediately on admission, she will be, after this work, she'll be given hemodialysis to stabilize her. Considering that she had hypoxia, she has to be given oxygen support also. And we have considering that.
How you will position anti-calemic drugs treatment in this patient on arrival, or directly you will start dialysis, ultrafiltration, because patient is in pulmonary edema also?
Yes, sir.
How you will place anti-drugs? Or you will for dialysis?
Since she presented with the pulmonary edema and hypoxia, we will start her on hemodialysis directly, sir.
Okay. So during hemodialysis, if you start with ultrafiltration, there may be chances of worsening of hyperkalemia during dialysis. So how we will manage?
We will have to give her anti-hyperkalemic measures such as glucose with insulin, dextrose with insulin infusion, along with if ECG changes are there, then calcium gluconate also has to be added. And we can add sodium polystyrene sulfonate, because the rebound hyperkalemia can occur since she is in acute renal failure. And other than that, if
so right, you have done dialysis in this patient, then
also, since she has fever now, in workup for infection also has to be done. If there is any source of infection, then we have to give IV antibiotics also. Then now, considering her clinical picture, if there is no infection, then we can start her on induction therapy with IV methylprednisolone at 5.
How you will rule out infection in this patient? How you will plan your aggressive immunosuppressive therapy? So
we have to send her blood and urine culture. First in CBC, we will see if there is leukocytosis. Then urine analysis, because there is active sediments, it is difficult to say if it is UTI. Right. So blood and urine culture has to be sent. Then since HRCT chest is done, we can look for evidence of infection in that. And procalcitonin also will help us guide if it is elevated. And sorry, sir? Viral markers. Yes, sorry, I forgot to tell. Viral markers also have to be done. Hepatitis B, hepatitis C, we have to, and HIV.
Any parasitic infections?
Parasitic infections.
Strongyloides?
Yes, strongyloides, because they can.
What investigation you usually send for this?
Sir, eosinophils.
Okay.
Stool analysis versus and over.
So you have ruled out infection in this patient.
Yes.
You will stabilize this patient on dialysis, ultrafiltration, and then you will go for biopsy. You will wait for biopsy report, or you will start treatment in this particular patient.
For this patient, since she has a life-threatening disease, we won't wait for biopsy because it is difficult to perform biopsy in a patient who is ventilator dependent. So we'll start off with induction. we'll give intravenous methylprednisolone 500 mg to 1000 mg, 3 pulse doses. And this has to be followed, this has to be accompanied by immediate start of plasmapheresis. So since she has diffuse alveolar hemorrhage with hypoxemia, daily plasmapheresis has to be done, 40 to 50 ml per kg with 5% albumin as the replacement solution. And at up to 5 to 7 sessions of plasmapheresis may be required. However, it has to be continued till she improves clinically. And along with this, she has to be given induction with cyclophosphamide-based regimen. It can be cyclophosphamide alone or cyclophosphamide along with rituximab. So cyclophosphamide alone, the regimen that is followed is 15 milligram per kg, given once in 15, initially on day 0, and repeated every 2 weeks, 3 doses. After that, doses are repeated once in 3 weeks.
So induction therapy with IV methylpred, cyclophosphamide, and plasma exchange in view of the pulmonary hemorrhage. Which trials support this therapy?
So rituximab's trial, Cyclops trial has compared IV cyclophosphamide and oral cyclophosphamide, and it has
right. Which trial favored plasma exchange?
MIPEX trial has favored plasma exchange, sir. It has.
And what is the current status of plasma exchange?
As after Pexiva's trial, it has been found that in patients with GFR less than 50 and diffuse alveolar hemorrhage, there is no much beneficial role of plasmapheresis. However, they say that KDIGO guidelines say that in patients who have creatinine more than 5.7 with oliguria requiring dialysis and those with hypoxemia secondary to DAH, we can still consider plasmapheresis.
So what was the difference between MAPEX trial and Pexiva's? In
MAPEX trial, they compared IV methylprednisolone 3 doses along with plasmapheresis, which was given in addition to cyclophosphamide and cyclophosphamide induction followed by azathioprine. Whereas in Pexiva's trial, patients were given induction and the comparison was done with the plasmapheresis and conventional dose steroids, plasmapheresis with low dose steroids, no plasmapheresis with the conventional or low dose steroids. And they found that low dose steroids was similar in efficacy and better in terms of reducing side effects. So that was one finding. The other finding was that plasmapheresis versus no plasmapheresis, there was no difference in 12-month primary.
So after Pexiva's, we are preferring low dose of steroid for induction.
Yes.
So what are the other trials for induction therapy?
RAVE trial is a trial for rituximab induction, sir. And it was compared with cyclophosphamide induction. And they found that rituximab was non-inferior to cyclophosphamide. And it was given at a dose of 375 mg per meter square. Once a week, 4 doses were given. And no maintenance with azathioprine.
So in this particular patient, will you prefer cyclophosphamide or will you prefer rituximab for induction in this particular patient?
So RAVE trial did not include patients with creat more than 4 milligram per DL. So considering that she had creatinine of 12 at presentation and diffuse alveolar hemorrhage, we have to consider cyclophosphamide.
Okay. So what are the points in favor of using cyclophosphamide in this patient? One is very severe renal failure and presence of pulmonary hemorrhage. What else? Because your patient is having MPO.
Yes.
Vasculitis.
Yes.
So what is the chances of relapse in this patient?
Around
PR3.
Around 40% of ANCA patients relapse. However, the relapse is less in MPO when compared to PR3. Rituximab is preferred in PR3 positive patients because RAVE trial has shown that the outcome is good at 6 and 12 months in PR3 positive patients compared to cyclophosphamide.
So how long you will give induction therapy in this patient?
So since she is MPO positive, the induction therapy has to be continued for the cyclophosphamide based induction therapy is given 15 mg per kg, once in 2 weeks, 3 doses, followed by once in 3 weeks, 3 doses. And it can 4 more doses of that can be repeated if she has not attained the remission. So after that remission induction, we can give maintenance with azathioprine.
No,
And
I'm not talking about maintenance.
yes,
Of induction therapy.
yes. So one option is to give plain cyclophosphamide based induction, sir. The other option is to give rituximab plus cyclophosphamide, where rituximab is given 375 mg per meter square and
Suppose
day
your
0.
patient remains dialysis dependent.
Yes, sir.
Patient remains dialysis dependent. She doesn't improve. Then
So for up to 4 months, we can continue. Give her induction therapy and wait and watch for response. Even after 4 months, if she is dialysis dependent, then we have to consider tapering and stopping her immunosuppression. Because studies have shown that patients with ANCA vasculitis can become free of dialysis dependency after even up to 4 months after the initial presentation.
so what induction you have given in this patient?
Sir, actually we had started off with the Sowmondal and plasmapheresis and we were planning cyclophosphamide. However, she developed superimposed LRTI and sepsis. We couldn't give, and she was her cultures showed growth of Klebsiella. So we couldn't give cyclophosphamide as long as she was ventilated. After that, we performed her biopsy. And we were planning immunosuppression, but she was still in sepsis and she was requiring TG cycline coverage antibiotics. So then we were just giving her oral steroids and waiting to give cyclophosphamide. However, after about 3 weeks of hospital admission, she developed sudden onset DH episode one day with immediate cardiac arrest. Meanwhile, her biopsy report had come. There was crescentic glomerulonephritis, so we couldn't give her.
What do you expect in renal histopathology in classical ANCA-associated vasculitis?
So patient will have fibrinoid necrosis, that is necrotizing fibrinoid necrosis involving the blood vessels, causing necrotizing vasculitis, and they can have crescentic glomerulonephritis. So
classically, it is necrotizing crescentic GN.
Yes.
Usually they are focal and many times they are segmental.
Yes.
What is the status of the uninvolved glomeruli in ANCA vasculitis?
In ANCA vasculitis, the uninvolved glomeruli do not show any inflammation, unlike immune glomerauli.
Based on that, how you classify ANCA-associated vasculitis?
I didn't get you, sir, as in based.
Have you heard about the classification of ANCA-associated?
Yes, sir. Burden et al. Classification.
Yeah.
So Burden et al. Classification classifies on the basis of a percentage of glomeruli that are involved. So if more than 50% of the glomeruli are normal, it is called as focal classification. If more than 50% of the glomeruli show cellular presence, it is crescentic variant. If more than 50% of the glomeruli are sclerosed, it is a sclerosed variant. And if there is mixed crescentic and sclerose, it is mixed variant. So the prognosis is best in focal variant, followed by crescentic, followed by mixed, and worst in sclerotic variant.
So one is involvement of the glomerulus. What about interstitium? What about medulla?
Medullary there can be medullary angiitis of the vasa recta, sir, and this can sometimes cause papillary necrosis also.
Okay. So papillary necrosis can occur if vasa recta are involved, and they are usually bilateral. And almost all papillas are involved.
Okay.
So these are the few histological points while discussing ANCA-associated vasculitis. And rightly you have said that patient has developed infection during the hospital course and during management. So control of infection is very important. So what about the quality of life in ANCA-associated vasculitis patients?
So around 25% of the patients can progress to ESRD in ANCA vasculitis. So survival also on the basis of ESR. I don't remember the exact survival.
Okay. So now coming to the maintenance phase of the treatment. What are the
Yes.
drugs?
So the drugs that are available are azathioprine, rituximab. Then some patients MMF also can be considered if it is non-organ threatening, non-life threatening.
Right.
Methotrexate is the other available options.
So what are the trials which favor rituximab as maintenance therapy?
Rituximab maintenance therapy is favored by Main-Ritz-N trials. So there is Main-Ritz-N, Main-Ritz-N 2 and Main-Ritz-N 3. Okay. And also Ritazarem trials. So Main-Ritz-N trial, in Main-Ritz-N all the trials, the induction was given with cyclophosphamide, and maintenance was given with the rituximab following a schedule of day 1, day 14, and 6, 12, and 18 months. In Main-Ritz-N 2 trial, they compared fixed dose regimen, that is day 1, day 14, 6, 12, and 18 months, along with the as per need regimen that was done on the basis of CD19 levels. If it
that was the scheduled versus on-demand issue.
Fixed.
What was Main-Ritz-N 3 trial?
In Main-Ritz-N 3 trial, the patients who successfully completed Main-Ritz-N 2 and had BVAS score of 0 at 18 months with no clinical disease activity, they were given extended rituximab maintenance, which was 500 mg rituximab given biannually. So they gave at 0, 6, 12, and 18 months. And
they got additional 4 doses of rituximab.
Yes, sir.
So in policy, the low dose, longer duration rituximab was more effective in reducing the relapse of the disease.
Relapse. Yes.
Okay. So what is rituximab?
Rituximab is a CD20 monoclonal antibody, sir.
It is
Sir?
It is chimeric.
Yes, a chimeric monoclonal antibody.
Chimeric monoclonal.
Yes.
What is humanized anti-CD20?
Sorry, sir?
Rituximab is chimeric anti-CD20. And do you know any humanized, totally humanized anti-CD20?
No, sir, I'm not aware.
Because that is also available and that is being evaluated.
Okay.
So that we can further suppress the B cells in these patients who are regularly producing the autoantibodies. What are the newer drugs which are in pipeline for treatment of ANCA vasculitis?
Sir, C5a receptor antagonist avacopan, it is being studied it was studied in phase 3 trial, Advocate trials. So that was for maintenance. It was compared with steroids actually. So they found that avacopan given 30 mg BD for maintenance in comparison to steroids, it was non-inferior. So it can help to reduce steroid toxicity in the maintenance phase.
So what was the biopsy finding in this patient, your patient?
Sir, this patient, her renal biopsy, light microscopy showed 16 glomeruli. 3 glomeruli were obsolescent. 4 viable glomeruli showed fibrocellular crescents. 6 viable glomeruli showed circumferential cellular crescents. And there is collapse of capillary loops with wrinkling of capillary basement membrane. There was interstitial inflammatory infiltrate of lymphocytes and plasma cells. Tubules were normal. Visualized vessel was normal. Immunofluorescence showed no immune deficits.
I think there is some problem in the network. Am I audible?
Yes, sir.
Yeah. So what is the diagnosis after biopsy?
So she is a RPGN with crescentic glomerulonephritis because more than 50% of the glomeruli show crescents, secondary to MPO ANCA vasculitis, presenting with the diffuse alveolar hemorrhage.
What is
Pulmonary.
dual positive? Have you done anti-GBM in this patient?
Yes, sir. Anti-GBM was negative.
Negative.
Yes.
So tell me something about dual positivity.
Patients who are ANCA positive, around 5 to 10% of them can be anti-GBM positive, and patients with anti-GBM disease, around 25 to 30% of them can be ANCA positive. So anti-GBM disease patients who are ANCA positive, that is dual positive patients, at presentation they behave like anti-GBM disease, so they have to be managed aggressively with plasmapheresis. Whereas later on in the course of disease, plain anti-GBM glomerulonephritis undergoes remission usually after around 6 months, whereas dual positive patients, they behave like ANCA vasculitis and can have frequent relapses, and the progression to ESRD is more. So these patients who are dual positive have to be treated with the maintenance phase, just like how we treat ANCA vasculitis.
Okay. And in some situations, you find both PR3 and MPO are positive. So what are those conditions?
Patients who with the drug-associated ANCA vasculitis, that is levamisole adulterated with, cocaine adulterated with levamisole. Then drugs
What are
such
the other
as
common drugs? Common drugs.
propyl thiouracil, then hydralazine, minocycline.
Usually the titers are very high in this.
Okay.
Atypical ANCA.
Atypical ANCA may be seen in patients with inflammatory bowel disease, sir, and malignancy associated also they can have.
Sometimes you get positivity on indirect immunofluorescence, but
Yes.
the test is negative by ELISA. So there is some ANCA, but it is not PR3 or MPO. So mostly this comes under category of P-ANCA. So this can be seen in the conditions which you have mentioned, that is inflammatory bowel disease or endocarditis, sort of things. How do you do prophylaxis in these ANCA vasculitis patients when you are managing with induction or maintenance therapy?
So we have to give immunization first, vaccination. After ruling out hepatitis B, we have to give hepatitis B vaccination, then influenza vaccination and pneumococcal vaccination. And antibiotics we give trimethoprim sulfamethoxazole prophylaxis has to be given for the duration of induction immunosuppression. And if we are giving rituximab maintenance, during rituximab maintenance.
So how long you give prophylaxis for pneumocystis zero-VC?
6 months prophylaxis is told, sir. But if rituximab maintenance is there, during rituximab maintenance also we have to continue.
Among all these immunosuppressive agents, steroids, cyclophosphamide, rituximab, which is most toxic, which affects the quality of life of the patients?
Cyclophosphamide can cause recurrent infection, sir. But
yes, acute toxicity is high in cyclophosphamide, but overall the dose of high dose steroids, they greatly influence the quality of life in these patients. So whenever you taper the dose of steroid, and when it becomes the daily dose is less than 20, then you usually stop the prophylaxis against pneumocystis zero-VC. So what are the other drugs? If patient is not tolerating Septram, then what are the other drugs we can give for pneumocystis prophylaxis?
Sir, Dapsone can be given, sir.
Yeah.
Then
what else?
Lyophilized inhaled pentamidine.
Pentamidine, right. Yes. How you manage steroid-induced osteoporosis?
Sir, we can give calcium and vitamin D supplementation, and bisphosphonates also has to be given, sir. So that will, along with monitoring of DEXA scan once a year.
Anything for Candida prophylaxis?
fluconazole can be used.
Fluconazole. So I think you have done well, Dr. Anwitha.
Thank you, sir.
So time is also up. So Dr. Pratik.
Yes, it was an excellent and very good discussion. I was just listening, so I am late to respond. So it's a complete discussion. And for the students, just my job is to slightly summarize. Anwitha, you have presented a 60-year female who presented with pulmonary renal syndrome in form of RPRF and RPGN and alveolar hemorrhage. Sir has asked you about whether from the history, are you sure it is an ANCA-associated vasculitis or immune complex mediated? And he has also asked you to take the detailed history regarding to confirm your diagnosis from the history and the classification of small vessel vasculitis and this what are the positive finding in your patient and what are the lung manifestations of the vasculitis, what are the treatment options, where how when depending upon your lung involvement, the treatment option, how it varies. And after your examination, he has asked you for the test and importance of complete blood count and also the this renal function test and how the level of creatinine is, how it is important, especially in such cases in planning of therapy, and how it is different in small vessel vasculitis and anti-GBM disease. And he has also asked you about this importance of the complement level. If the complement is low, he has asked you about which are the situations where both C3 and the C4 are low, and some situations also where the complements are high. Okay, and this is regarding these serological parameters, ANCA, different methods, the immunofluorescence, ELISA, or both, how we'll send the samples, and what are the importance of testing this antigen. And in your investigation, you have told that it's a quite severe renal failure. And then he asked you about this plan of treatment, how to plan for your dialysis and how to take care of the hyperkalemia, how to rule out the infections. He has asked not only for the culture, also the viral markers and the parasitic infections, especially strongyloids. And he has asked you whether you should wait for biopsy in such a severe disease or you should start very early treatment. And regarding the treatment, methylprednisolone, plasminoxin, and cyclophosphamide, you told, and he asked you which trial favors this. And he has also asked you about the trials of the plasmapheresis matrix versus Vexivas trial. What is the difference in the study design in between these two trials? What are the other trials regarding inductions in favor of rituximab as well as in cyclophosphamides? And in your case, which this is very important, what induction will you start, either cyclophosphamide or rituximab? And what are in which situations cyclophosphamide is a priority drug in terms of treatment, and what is the effects on the severity of the disease and relapses, and how long induction therapy should be given. If the patient doesn't improve, then what, whether you should stop or continue or intensify or change your therapy. And about immunosuppression of the patient, he has asked you. And then he asked you about the histopathology, what is the typical findings in the ANCA vasculitis, and what is the specifically he has asked you in the non-involved glomeruli, and what is the importance, and what is the this is classification based on that, how the medulla and the interstitium is involved, papillary necrosis can happen, and what is the quality of life of the ANCA vasculitis. And he has asked you about the maintenance, what are the trials in favor of maintaining maintenance therapy, and what is about rituximab, different doses of rituximab, high dose versus low dose, long duration versus short durations. And he has asked you something about what is rituximab, whether there is any humanized form available or not, and what is its advantages. And he has asked you about some newer drugs, and you described biopsy in the finding, and he asked you whether you will do the anti-GBM testing or not. What is a dual disease when the PR3 and MPO both are positive? Which are the situation, which drugs can cause it? What is atypical ANCA? And when there is a discrepancy between immunofluorescence and ELISA, And he has asked you about the prophylaxis, specifically the pneumocystis. How long will you give? Which drug will you give? If he is intolerant to this is a sulfur drug, then what will you give? And he has asked you about the candida infections. And he has given importance to the steroid treatment of overall quality of life, because it may be a simple drug, but it has a long impact on the life of the patient in terms of different cardiovascular and osteoporotic diseases and the quality of life. So probably he has discussed everything, and all the students probably has learned learned a lot about these vasculitic diseases and how to approach. This is a clinician perspective. You can see he has asked everything which is very much clinical. Okay, and you have answered also very well. Just one suggestion of mine is just a slightly bit slow in your presentation.
Yes.
You were extremely good. You just present slightly slowly, because in your age your reflexes are very strong, but the examiners may not comply. And every discussion you just give a short summary, so that the discussion becomes much more easy.
Yes.
So you stay here, Dr. Ram, you stay here. We're starting the discussion. Very good discussion. I was just delighted. It was excellent discussion. In the next few minutes, we'll be discussing some OSCE questions, because we don't know the next examination will be OSCE or the clinical, specifically the DNB students. Dr. Rabiranjan is there. Ravi is our pass out, and he is presently working as a consultant nephrologist in Ramakrishna Institute of Medical Science. Very bright student. He has prepared these OSCE questions, and he will presenting. Anwitha, you have to read the questions and take the question and give the answers. And after the discussion, your examiner will may give his input if you wish to. Okay,
Yes.
Ravi, you take charges and start these OSCE questions.
So good morning. Thank you, sir, for the compliments. For the next few minutes, we'll be discussing the OSCE sessions. For last 2 years, we have been facing OSCE questions in DNB examinations, and probably a few more examinations will be based on OSCE. We don't know yet. So let us go into this. So let's start. Mr. Vijay. So should I go through the question, or Dr. Anwitha will you yourself?
I'll read up, sir.
Okay.
A 25-year-old female patient had full-term delivery via LSCS. She has decreased urine output post-LSCS, difficulty in breathing for 1 day. She has history of postpartum hemorrhage, was transfused with 3 units of packed cells intraoperatively and 2 units of packed cell post-LSCS. She had regular antenatal checkup with no history of high blood pressure, no previous history of hypertension, diabetes, TB, or ischemic heart disease. On examination, she is afebrile, conscious oriented. Pulse is 110 per minute, BP 140 by 80, respiratory rate 26 per minute. Pallor is present, no icterus cyanosis clubbing. Systemic examination is unremarkable.
Next slide.
She developed oliguria and increased serum creatinine level that necessitated dialysis. Her lab parameters were hemoglobin of 8.2, total count of 12,300, platelets 1,80,000, creatinine of 4.3, total bilirubin is 0.8, AST, ALT is 42 and 50, and LDH is 223.
Okay. So at this point of time, will you give some differential diagnosis for this patient? What might be the cause of this renal failure?
My first differential diagnosis would be postpartum acute cortical necrosis, sir, secondary to postpartum hemorrhage. Then other thing would be if she had developed shock during that postpartum hemorrhage, shock associated acute tubular necrosis. And since her lab parameter is not showing high LDH, TMA would thrombotic microangiopathy would be lower down in the differential.
Okay, so let us go to the next slide. So this is the contrast CT delayed image. So you have already given some differentials.
Yes.
Why do you think this is cortical necrosis?
So,
What are the points in favor?
In the postpartum period, when there is postpartum hemorrhage, the chance of shock-associated acute cortical necrosis is, I mean, it's a known phenomenon, sir. So acute cortical necrosis, since the patient has presented with oliguria necessitating dialysis, that becomes a more likely.
So this patient is having renal failure with progressive oligoanuria. She had a history of blood transfusion during and immediately post LSCS. All the blood level parameters regarding the LFT LDH were normal.
Yes.
And probably she might have some kind of hypotension during that LSCS. So causes of other postpartum AKI. What are the other causes? Not in this case.
Yes. If there is puerperal sepsis, sepsis associated ATN, ATIN can happen. Sir. So, and during LSCS, if there is inadvertent ligation of the ureter, then patient can develop acute onset renal dysfunction.
You mean it's bilateral damage?
Yes, sir, bilateral.
Okay. Anything else?
Then, if the patient has peripartum period, if the patient has had acute fatty liver of pregnancy, then associated patient can have AKI, and TMA is the other pregnancy associated TMA.
Okay. And what about HELP?
Yes, sir. Sorry, I forgot. HELP also can be associated.
Okay, next question. Next. So how will you manage this patient and what is the prognosis in this patient?
Management at present, since the patient is oliguric and has rising serum creatinine and she's immediate postpartum, we will have to continue her renal replacement therapy, hemodialysis, and we have to watch for renal recovery. I don't remember.
What is the chance of renal recovery in cases of severe acute cortical necrosis?
I don't remember.
So what you usually see in those patients, those who presents with acute cortical necrosis post LSCS, most of them do not recover in long term, and they have a very poor prognosis. They have to stay on dialysis for the rest of their life. So prognosis is not so good. Next question. So other causes of cortical necrosis other than pregnancy associations?
Acute TMA can cause cortical necrosis. Then patient causes. I don't remember, sir.
So it can be sepsis, burn, severe dehydrations, pancreatitis, all these cases of SARS, snake bite, of course, that can lead to. And the post-transplant period, you can see cortical necrosis in post-transplant scenarios.
Yes.
So all these are the, okay. Om Kumar sir, do you have any question regarding this?
Please carry on.
Okay. Okay. So next slide.
49-year-old male, chronic smoker with no comorbidities, has presented with acute onset hematuria for 10 days, reduced urine output for 6 days, pedal edema for 6 days, progressive dyspnea for 3 days. His HB is 10.1, total count is 15,000, platelet test 230,000, creatinine is 7.2, urea 140, urine routine examination is showing protein of 2+, RBC 40 per high power field, WBC 2 per high power field, and he was dialyzed once. On examination, pulse is 92, blood pressure is 164/100, respiratory rate is 23, saturation is 84% on air, respiratory system examination is showing bilateral post crepitations, cardiac and CNS examination is normal.
Next slide. Okay, so look into the picture. The all A to F are showing some glomerulus, and they have typical findings.
Yes.
What do you think? What is the overall impressions looking at all the pictures, all the glomerular?
It's possible anti-GBM disease, sir. There is a glomerular Bowman's capsule rupture is there in slide E, and there is cellular presence that are seen.
Okay, by
And
seeing into the light microscopy, it's not possible to
yes,
think whether
yes,
this is anti-GBM or
yes.
whatever it is. But what is the diagnosis from this?
Crescent,
Yeah.
RPGN with crescent, sir. I can't say with this crescent.
Okay. So all these light microscopy pictures showing the different kinds of crescents.
Yes.
With some are focal, some are circumferential, and
Yes.
E showing the rupture of the GBM.
Yes.
So, and what kind of crescents are these? Are they cellular, or are they fibrocellular? Are they only fibrous?
Sir, cellular presence are seen, sir.
So all the 6 glomerulars are showing cellular crescents. So
Yes.
I picked a case where all the glomerulars, all the crescents are of same age.
Monomer.
Okay. So next slide. Now you can see the linear IgG deposits along the basement membranes.
Yes.
Okay.
Yes.
Glomerular capillaries. So next slide. So now you have some definite diagnosis in your mind, and that is
anti-GBM disease, good pasture syndrome, pulmonary renal involvement.
Sure. So this was simulating your today's case.
Yes.
Already discussed some of the differentials of pulmonary renal syndrome. So let us go to the next question. Renal biopsy findings we have discussed, and now you can say, what are the indications of immunosuppressive therapy for this above case? For this patient, whether you want to start immunosuppression or you don't want.
So this patient, even if his creatinine is above 7, he only has cellular crescents. And patients with anti-GBM disease with cellular crescents, we can give a trial of immunosuppression for up to 4 weeks, and we can see for response. So if there is no response, then we have to stop his immunosuppression. So this patient, we can start with immunosuppression with plasmapheresis, since he has features suggestive of DAH probably because of hypoxia.
So, okay. So in this case of anti-GBM disease, initiating immunosuppressive therapy depends on the forthcoming prognosis. So we have to predict what might be the prognosis in this patient. And that depends on the number of or the percentage of crescents in the biopsy. And the on presentation, how they are presenting, whether they are having a very high creatinine, whether they are presenting on presentation within 48 to 72 hours, they are requiring dialysis or not, and if they have renal pulmonary involvement of diffuse alveolar hemorrhage. If there is diffuse alveolar hemorrhage, and if the presentation on presentation creatinine is less than 5.8 as on studies, or the patient is not dialysis dependent from very beginning, we have to predict that this patient might respond to immunosuppressive therapy, and we should start immunosuppression. And this is just opposite to that of ANCA-associated vasculitis, where in very severe cases, we have to start immunosuppression. But in anti-GBM, if the presentation is, renal presentation is very serious, like patient is dialysis dependent from very beginning or very high creatinine, and 100% presents on kidney biopsy. So in those cases, the prognosis might not be so good. So we might not emphasize on immunosuppressive therapy in these patients. Okay. So let us go to the next question.
She's a 64-year-old female who was evaluated for chronic kidney disease. Her BP is 170 by 100. Serum creatinine is 2.1. Urine examination showed 4+ proteinuria and sediment with microscopic hematuria. WBC is 10 to 15. Kidney biopsy is performed.
And you have been given a picture of urine microscopy. What is it?
This is RBC cast.
Okay, this is a cast, and of course, this is a cast with cells, and this is not possible to say whether this is RBC or WBC or what else. So it's better to say it like a cellular cast.
Cellular cast.
Okay, next slide. So light microscopy. What stain is it?
So there is past staining, sir, because
The basement membrane is looking black.
Oh, sorry, there is silver staining of the basement membrane. So
Okay.
bronze methanamine silver stain.
So describe about the mesangium.
There is mesangial expansion, sir.
Okay.
And
that is silver.
nodular expansion.
That is silver negative.
Yes, sir, silver negative.
And there is no specific nodular kind of presentation, not nodules and all.
Yes.
And regarding the cellularity?
It doesn't appear hypercellular, sir. I can see 3 cells. It is
Okay.
just a plain mesangial expansion.
Okay. So some kind of mesangial expansion without hypercellularity, and this
There is no multi-layering of.
Okay. And is silver negative. So next slide. And it is definitely strongly positive for IgG.
Yes.
Along the capillary basement membrane.
Yes.
Okay, so next slide. What is the EM findings here? You can see the basement membrane.
Yes. There are
one side it's a urinary space.
Yes.
And on the other you can see some podocytes with food processes.
Yes.
And the basement membrane, can you see something?
There are fibrillary.
Okay.
Fibrillary structures. Not
some kinds of fibrils deposited in the basement membrane.
Yes.
So what do you think?
Fibrillary GN with since there is mesangial expansion.
These fibrils are arranged, how they are arranged?
They're random.
Yes. Okay. So they are not like arranged in stalks or like cigars.
Yes.
And we can't say what is the length of these fibrils without measuring it. So next slide. So EM findings, so there are some kind of fibrils deposited at random, and the length of those fibrils we don't know.
Yes.
Any special marker for if you are suspecting this to be a fibrillary GN? Any special?
DNA JB79.
Okay, DNA JB9. And
JB9. Yes.
What is DNA JB? What is DNA J actually? What is it?
Sir, it is a protein that is involved. I forgot.
Okay, this is a group of heat shock proteins belonging to the family 40. And so we have this DNA JB9 positivity in specifically fibrillary glomerulonephritis. And we don't see this marker to be positive in other fibrils like amyloid or in secondary to myeloma or microtubular. All those are negative. So this helps us in picking up the diagnosis, very sensitive marker. Yes. So the etiology, how this fibrillary GN occurs, what might be the causes of this fibrillary GN?
Sir, it can be seen in patients with autoimmune disorders such as rheumatoid arthritis, sarcoidosis. It can also be seen in diabetes. It can be seen in hepatitis B and hepatitis C. So
some we have already told that it can be fibrils, can be secondary to amyloid or fibrillary immunotactoid, diabetes, secondary to autoimmune diseases. Yes. Okay, all those are correct. But regarding the fibrillary GN itself, so this can be a primary one or can be secondary to some autoimmune diseases like SLE and rheumatoid arthritis, others. It can be secondary to some malignancies like myeloma, MGRS. So MGRS, we often find fibrillary GN secondary to MGRS.
Yes.
So treatment, how will you treat fibrillary GN and what is the prognosis of this kind of patients?
Treatment involves treatment of the underlying cause, sir. There's no specific
In
treatment.
cases of secondary, definitely. And
there are trials that have tried plasmapheresis for fibrillary GN, sir, but there is no proven efficacy. And immunosuppression also, MMF has been tried, but there's no proven efficacy. What I remember.
rituximab?
I am not aware, sir, of rituximab.
Okay, so rituximab is often being tried in specifically in cases of multiple myeloma associated fibrillary GN. This depends on the clone, on which is the specific clone, whether this is B cell clone or plasma cell clone, and depending on that, if it is B cell clone related fibrils, then we can treat those patients with rituximab. If it is plasma cell clone related fibrils, then we should treat it with bortezomib based chemotherapeutic regimen.
Okay.
And regarding the prognosis, it all depends on the underlying MGRS or autoimmune disease or malignancy, whatever it is.
Yes,
it varies.
Yes,
so sometimes it can be very good, sometimes it can be bad if it is secondary to some malignancy which is not responding to chemotherapeutic regimen. So
yes,
next slide. So just going through those fibrils, usually we should differentiate between different kind of fibrils by doing initially with a silver stain. If it is positive, it can be of collagen, positive because of the collagen. So this can be collagenofibrotic or in diabetes. If it is Congo positive, then it is secondary to some amyloids, and the fibrils are of very short length, 7 to 15 or 16 nanometer, and they are arranged randomly. If it is negative, then it can be because of the fibrillary or MIDD or immunotactoid or cryoglobulins, and the different tubules have different fibrils have different length and arrangements. Next.
Yes.
So we have to often differentiate between if it is a fibrillary kind of electron microscopy findings, we have to differentiate between the amyloid, fibrillary, and immunotactoid.
Yes.
Next. And already Kedigo has mentioned that DNA JB9 is a very sensitive and specific marker for fibrillary GN. Okay, next slide. So this is the last case. Please go through it.
A 27-year-old woman delivered a healthy child at 37 weeks by cesarean section. Her BP is 160 by 100 and urine is showing 3+ albumin. She developed elevated transaminases, thrombocytopenia, and LDH of 900. Her serum creatinine is 4 mg per dl. Her urine protein is 3 gram per day, and she was started on hemodialysis. No prior medical history and limited prenatal care. Her family history was positive for a sister with kidney failure during pregnancy.
Okay, so you have been provided with a peripheral smear and
Yes.
urine microscopic examinations.
Yes. So
What
peripheral smear is showing schistocytes are there, hat-like cells. And urine microscopy ring forms with
cells with some blebs.
yes, sir. Acanthocytes are there, sir. Vesicular outpouch.
Okay. So acanthocytes, echinocytes, these are actually different kind of dysmorphic RBCs, isn't it?
Yes.
Okay, so you have a lady with hypertension, proteinuria, dysmorphic RBCs, peripheral blood smear showing cystocytes, high LDH level, thrombocytopenia, family history of renal failure during the pregnancy in case of a sister. So next slide. So these are different kinds of dysmorphic RBCs. You can find it easily on books: discocytes, echinocytes, annulocytes, ghost cells, schizocytes, podocytes, nizocytes, acanthocytes. So different kinds of those you have to identify if in OSCE sessions. Next slide. This is the light microscopy picture of for this patient. What is the characteristic findings?
So there is
Glomerular capillary loops. Are they patent?
no sir.
On the left-hand side.
Thrombi.
Yes. So all those, most of the loops, except a few,
Yes.
they are almost filled up with something
Yes.
which are not cells.
Yes.
Those are thrombi.
Yes.
So this is a picture showing.
Thrombotic microangiopathy.
Yes, probably
Probably.
thrombus occluding all the capillary loops. On the right-hand side, in the vessel, likewise, there are some deposits. So probably that is also a thrombi.
Yes.
Next slide. In it's IF showing negative, and in EM, what is the findings?
So subepithelial.
So you can see the basement membrane has been widened in some places.
Yes, sir.
And this is some kind of
Subepithelial.
There is no hump. This is not hump, or like the in no immune complex depositions. Those are not here.
Effacement.
These are some translucent areas within the basement membrane causing separation of the two layers of the basement membrane. So these are like false kind of basement membrane, or the double contouring of the basement membrane.
Okay.
With some translucent materials within it. These are not immune complexes. Okay. So biopsy findings we have discussed. So what is it in your mind regarding the diagnosis?
Sir, atypical HUS is a possibility, sir, because there's family history also. Okay.
At this point of time, we can only say this is a kind of thrombotic microangiopathy, and which is associated with pregnancy.
Yes.
And this can be a pregnancy associated TMA,
yes.
or this can be a primary TMA,
yes.
like atypical HUS,
yes.
which has been precipitated during the pregnancy.
Yes.
Isn't it?
Yes.
So what are the investigations you would like to do?
Serum haptoglobin levels will help us confirm if there is intravascular hemolysis that is happening, sir. And C3 complement levels also will help us to identify. And since there is family history, if atypical HUS is confirmed, we can do CFHR mutation analysis also.
Yes, genetic
and
study.
C3 nephritic factor antibody levels.
Okay. And any complement levels?
C3, C4, CH50.
Other than this? What are the factors that that stimulate the lysis of C3 and which inhibits?
Factor B, factor H.
Okay, factor H and factor I inducers, factor D inhibitors. And do you know some C3GN, HUS or C3GN, which has some antibodies against these complements? So anti-factor H antibody, anti-factor H I antibody, complement factor I. So all those antibodies can be done.
Yes.
So anything about other causes of TMA other than HUS?
So pregnancy associated TMA itself can occur where von Willebrand factor levels, ADAMTS13 levels, which are slightly low, worsens during pregnancy, and this can present as thrombotic microangiopathy.
Okay. So ADAMTS13 level, that should also be done.
Yes.
So once you know that this is a TMA, how will you manage this patient? So
treatment for TMA, plasmapheresis has to be initiated because if there's any presence of antibodies against factors, so that will help us remove all of those antibodies. And
Okay.
next day of treatment.
She might need dialysis and the plasmapheresis, as you said, and any drugs. If suppose this is the typical HUS.
Eculizumab.
Yes, what is that?
Sir, it is C5 membrane attack complex inhibitor, sir. C5b9 inhibitor. But it's expensive. So.
Yes, very expensive and rarely available in India.
Yes.
Okay. So next slide. You have we have TMA, and we have to exclude TTP by doing Adam TS13, and there are several other causes of TMA, secondary causes like cobalamin C associated, pneumococcal infection associated, autoimmune disease associated, drug induced, bone marrow transplant associated, infection like CMV or Epstein-Barr virus associated, malignancy associated, post-transplant, pregnancy associated, and primary or atypical HUS. So we have to do all the relevant investigations in specific or appropriate situations. Yes. And we have to exclude the TTP by doing Adam TS13 activity and atypical HUS by doing genetic testing and complements levels or antibody levels.
Yes.
Okay, next slide. So this is the same kind of differential diagnosis, how we exclude one after another and reach to a specific diagnosis. And after we reach a diagnosis, we have to give plasmapheresis. Yes. And plus minus eculizumab if available and if affordable patient. Yes. Okay. Next. This is what we have already discussed. Thank you. So these are the OSCE questions for today. Om Kumar sir, if you want to have some comments.
I think I congratulate Dr. Rabiranjan for very honest spot discussion of these slides, and the candidate has also done very well.
Thank you. Yes.
Whenever we discuss these type of life-threatening disease situation, and with the advent of so many very effective drugs with which we can treat the initial life-threatening condition, and we convert this condition into a chronic long-term diseases. So we have to know about the therapeutic futility of so many these immunosuppressive drugs, like you have discussed in the second case, that if the anti-GBM disease is having very high creatinine, so in those cases unnecessary use of immunosuppression should be avoided. So again, I want to emphasize that not only the newer mode of therapy, but we have to save the patient. We have to emphasize the role of prevention of infection and quality of life in these patients. And as usual, Dr. Pratik Das is eloquent. In 10 minutes, he summarizes all those things. So I enjoyed this session very much. Thank you. And thank you, Dr. Anwitha, for
thank you so much, sir.
Presentation and good discussion with the experts. Over to Dr.
Thank you. Your presence just make everybody smile. So we will be calling you often in next week after a few classes maybe. And you have to give some time for us.
Thank you.
Okay. Thanks, Ravi. Thanks, Dr. Anwitha. This is a good presentation, and OSCE sessions are as usual very good. So now we are closing the session. And the class.
Emotion Raju sir is also there in the line. I think Sir has joined. Anwitha madam's HOD.
Yeah, I've been listening to that, and thank you all, Dr. Om and Dr. Pratik, all of them. This very nice interaction, actually. Even I didn't expect that it can go so smoothly and so eloquently. It was really nice discussion. I learned a lot, actually. It's really good. Anwitha also, I feel she presented well. In fact, I don't appreciate the student so much, but her presentation is actually good and she did well. I congratulate, and more students should participate frequently and see that they have learned from the teachers across the country.
Yes, after all, it's your student. He's so good.
Thank you. Thank you.
We'll
Thank
be
you very much.
expecting you in discussion in some next few classes. Okay.
Yes, yes. Thank you. Thank you.
So
Oh,
I think Rajasthan is not connected, sir. I'll thank all the examiners and Pratik Das sir, Rabiranjan sir, Dr. Anwitha madam, and Sri Bhushan sir for their contribution for the medical students in the renal classroom. So we'll be soon announce other next event also after within few days. Please do continue to support. And if anyone wants to participate in our next upcoming session, I have posted in the chat box. You can contact through the mail ID or you can WhatsApp to the number so that we can include as a discussant for our upcoming program. Thank you. Thanks a lot. Thanks, Pratik Das sir. Thank Om Kumar sir. Thank you, Ravi sir. To close for the day. Have a happy weekend and advance happy Deepavali to all of our participants and of all doctors. Thank you. Thank you, sir.
Thank you, Doctor.